Michael in Texas says, as a 63-year-old recently diagnosed with prostate cancer, I listened very carefully when Clark gave his cancer update on the podcast. The information was interesting, but it could have been more useful. He left out key points by not revealing his Gleason score or give the technical name of the MRI. This information would have been helpful in my decision-making process as to whether or not to treat or become one who practices active surveillance. Please give the information on a later update. The surgeon wants to cut, the radiologist wants to radiate, but my main goal is to remain functional with the fewest amounts of side effects. I've been listening to Clark since he gave me the confidence to transfer money across the country to an online bank. Keep up the good work. And then we had several follow-up questions as well on social, so I'm just going to read some of those. Is UCLA the only hospital that does the prostate cancer surveillance? What initiated your prostate cancer diagnosis? A high PSA? Please name the MRI again. What you're able to do yearly is not just economically possible for 99% of everyone else. Is this specific MRI machine not available anywhere else in the country or just UCLA? And can working class regular people like school teachers and Starbucks employees who have regular health insurance afford active surveillance?
This is a great question, and the cost of the care I get at UCLA is not cheap, but most of it is covered by my insurance. And the reason insurance often will cover it is it's a lot cheaper for the insurance companies than somebody having the surgery or radiation or some combination of treatments for prostate cancer. I want to make it clear, this is one that anytime I do a once-a-year update now on my prostate cancer, and anytime I do, it generates a huge wave of questions and follow-ups. So just so you know, 14 and a half years ago, I was diagnosed with prostate cancer. There was an indication 15 years ago I had it. How did I end up on the path? First, a high PSA is one of the questions asked. And a high PSA is not necessarily an indicator that you have cancer, but it means you may. So then what happens, typically old school, is you would then have a biopsy. And the biopsy, I should tell you, is not a walk in the park. It's uncomfortable. But the biopsy may find a meaningful amount of cancerous cells. Those cancerous cells are then checked by a pathologist and graded if they are cancerous. And so one of the questions asked by a few people was about my Gleason score. My Gleason score is 3 + 3, 6. Generally, people that are candidates for active surveillance, which is roughly somewhere about 40% of people diagnosed with prostate cancer, will have a Gleason of 3 + 3 = 6, or 3 + 4 = 7. You can also have a 7 that's 4 + 3. 4 + 3 is more serious than 3 + 4. You can read about this at several medical institution sites to understand the difference in the nature of Gleason scores. But just remember that if you have a 6, you are normally an automatic perfect candidate for active surveillance. If you are a 7, the dividing line for most people in the practice of urology or oncology is that a 3 + 4 is potentially eligible for active surveillance. A 4 + 3 maybe not. So there are 2 companies working very hard to try to score some big money, with one with a urine test, another with a blood test, that will be able not only to determine just simply by a blood or urine test whether a man has prostate cancer, but also the genetic makeup of it. And it would take the guesswork out of who needs treatment and who does not. Both of these are in tests right now. When I, almost 15 years ago, entered active surveillance, it was not common in the United States, although it was in every other developed country. United States, if somebody was diagnosed, they immediately had surgery most often or some form of radiation. Today, the number of people doing active surveillance is way up that fit the profiles I talked about of the Gleason score. The MRI imaging I have, there are just a few places in the United States that do it. I wanted to pull up the actual name of it. And can we put this in notes? Because
Sure.
I know it's so technical. It's called a 3T MRI of the prostate with and without contrast and with 3D post-processing. So they're able to get an exact mapping of the cancer that's been inside my body for these last almost 15 years, that has not gone anywhere, not grown, and not been dangerous at all. So I've not had to have any treatment, no side effects, nothing. I do it once a year so that in the event that it is troubling, anything troubling is happening, then the protocol changes. I then have an MRI that is hyper-targeted because of the MRI I've had. Then I can have the biopsy based on the MRI. And what's neat is when they do the biopsy, it maps overlay where it is exactly where the questionable cells were. The last 3 years, there's been nothing for anybody to do a biopsy of because my MRI has been so clear. It's institutions that do the level of MRI. I don't know exactly. I know Mayo Clinic does. There are some university-based, Sloan Kettering in New York, Johns Hopkins in Baltimore. They are normally medical university-based hospital centers that do this level of work. They are trying to figure out who are the men that need treatment, who are the men that just need watching. Traditionally, in clinical practice, doctors are too busy to get involved in this level of detail, which is why it's usually at a university-based research hospital where these MRIs are done. And so this stuff is most of the research in prostate cancer. Most of the money is going to try to save the lives of people who have aggressive forms of prostate cancer, not more mundane like I have. But the reality is those of us who have non-life-threatening prostate cancer, at least at this point, need to really consider if we should have treatment at all. And that's what this is about. And that's why having the active surveillance is a choice. So going back to the affordability issue, if you have traditional employer-provided health insurance, remember the insurers are trying to hold down their overall costs. So it is to their advantage for a man to go through an active surveillance program with sophisticated monitoring than to have somebody have surgery or radiation and then potentially have lifelong side effects after that the insurer not only has had to pay for the treatment, but then they have to pay for the aftercare at a very high expense. So that's why insurers, if they're smart, pay for you to be properly actively surveyed so that it will save them money and their interests and yours end up exactly aligned. If you go to the website of the Prostate Cancer Foundation, pcf.org, for years I was a member of the board of PCF. There's a lot of educational material there for you that you can look at that'll walk you through what is a very confusing time, and know that there are people in medicine who mean well but are not up to date on, because they're so busy practicing, they're not up to date on the latest developments. And that's why you have to be your own patient advocate with any illness, not by reading who knows what weird message boards, but go to the source, medical journals, medical association information, individual disease organizations that are research-based, and read what's available there so that you can make the best decision. Do not be a sheep or a lamb, or what other animals would we say where you're going off to slaughter. You want to make sure that you are in control, making the best decisions as an informed patient. You did not go to medical school and fellowship and all that. It's true. But there's a lot you can learn so that you can ask the right questions, get the right second and third opinions, and make the right decision in your life. Because this is your health and your life we're talking about here.